Streaming's now commenced. Councillor Donoghue.
Okay, thank you. Good morning, everybody, and welcome to the Health and Housing Scrutiny Committee on Wednesday, the 13th of January. We'll start with introductions. Is everybody here, Hannah? Apart from Councillor Bell?
We haven't got Councillor Chow, Councillor Lee, and Councillor Wright. Oh no, Councillor Lee's here. Shall I do a roll call? That'll be easier.
Yes, please.
Okay, so Councillor Bell, he's just trying to get on. Councillor Chow is not present. Councillor Donoghue.
I'm here.
Thank you. Councillor Heslop. Councillor Heslop.
You're muted, Councillor.
I'll move on. Councillor Layton.
Present, and I've got my papers.
Thank you. Councillor Lee.
Yeah, I'm here, Hannah.
Thank you. Thanks. Councillor McEwen may be joining the meeting late. Councillor Newell.
I'm here.
Thank you. Councillor Tostevin.
Yes, I'm here, Hannah.
And Councillor Wright.
Hi, good morning.
Hello. And we've also got Councillor Nicholson.
Hi, Hannah, you okay?
Yeah. And we've got Joanne Todd, Gillian Curry, and Diane Lax from Health Watch.
Excellent, thank you. Next on the agenda is a declaration of interest. Do we have anybody interested? No. And third is the County Durham and Darlington NHS Foundation Trust accounts. Who's dealing with that, Hannah?
It will be Joanne.
Joanne.
Yeah.
Morning, Joanne.
Morning. I can actually see a hand up. Do I need to pause before I start?
Councillor Tostevin, your hand's up.
Oh, I just wanted to declare that I was on the Board of Governors for County Durham and Darlington Foundation Trust.
Okay, thank you.
Thank you. Hopefully you've all received the papers, and apologies that it was slightly late. I know that we all appreciate the COVID pandemic and the fact that it's very busy within the trust and all trusts nationally. So this is our 6-monthly overview report. It doesn't seem like very long since I met you to talk through the full report from last year because of the delays that we had with wave 1 nationally, but it is very much an overview report, and I've done it in the same format that we're all familiar with, but it's an overview. It doesn't hold the depth of information, and all I would say is please refer to the full report that's been uploaded for last year, and then we'll have the full report again going through 2021 when we get through to next June time. But it's just really to give you a position of where we're at in the first 6 months, and I'll pause again because I can see a hand up.
Thank you, Chair. I had a physical and virtual hand up. Apologies for my lateness, Chair. Can I declare an interest before the meeting started? I'm a lay member of Darlington Primary Care Network. I do apologise for my lateness, Chair.
Thank you, Councillor.
Okay, thank you. So the report actually covers the period between April and September of last year. Actually, I've just realised we're into January, so it's 2020. And I'll run through it. At this point in the year, some of our reports are annual reports when it's things like surveys. So on some of them, we will not have the update at the moment. But for where we're up to as it stands, I'll go through that with you, and then take any questions as you want to pull them through. So our first priority, and it has been a priority for some years now, is patient falls, and I would say our biggest safety risk in hospitals, due to the frailty of the patients that we see. So you will know from the last 3 years that we actually got a falls team, and we do have a falls strategy. and that's actually nearing the end of its first 3-year period. So time's flown actually. So that was a 3-year strategy, and we are currently working on building the next 3-year strategy, and we'll be ready to launch that in April alongside the new quality accounts. And I think that we'll build more priorities in, which we will share with you when we get to the point of launching the strategy. And I'll pause for Councillor Nicholson.
Yeah, sorry, Councillor Donoghue, I'm getting reports that the live stream is not working. Not sure who's watching Health and Scrutiny Mind, but yeah, it's not working. Slow Wednesday morning for some.
We'll just pause while we just check that.
Pause, okay.
I've been advised by my colleague in the office that it is working, so we can continue.
Okay, thank you. So we will share with you the new 3-year strategy. Our first 3-year strategy was very much about getting a picture of where we were, bringing in lots of external agencies to help us with the strategy and have a full system approach to falls management. And I know that yourselves were very involved with the first 3 years, so thank you for that. You can see from our 6-month position that within the acute hospitals, our falls per 1,000 bed days have been a little bit higher. We do try to have a threshold of 5.7 for acute hospital falls per 1,000 bed days, and by September we were running at 6.52. Councillor Tostivan.
I just wanted to ask whether it's possible to share your screen with us so that we can actually see what you're talking about. Obviously, I haven't got access to my data at the moment.
Right. I'll need to try and pull the report up. Gillian, do you have the report? Just amongst my emails, sorry, and it would take some looking at.
I haven't worked out how to look at the information and be part of the meeting yet on the same computer.
Okay. We'll try and get it up. I think Gillian's looking there. Okay. Can you all see it now?
Excellent, thank you.
Yeah.
I can't see it yet. No.
All
right. Yeah.
Yeah. Okay.
Well.
Yes. You have it, Councillor?
No, I can't see it as yet, but I did see it for a second, but then it's gone again.
I can see that.
Can people see it now? Or is
yeah.
Yeah. Okay. And
can everybody see it?
I can't see it, no, but carry on anyway. It doesn't. Okay. I'll just listen.
All right, and actually I can see a hand up as well.
Can I just jump in there, Joanne? It's Councillor Lee. I thought I'd try and do it while this was getting sorted out. From my limited experience, one of the types of falls is falling from the beds. We got basically 2 falls: people walking and dizzy and then falling, and then you've got the second one, which is they fall out the beds, and the beds tend to be too high. Now, I do know that in some wards there are beds which are lowered, so when the elderly do fall out, of course they're not as hurt. But my personal experience of a mother-in-law who experienced a few nasty falling out of bed, which seems in many ways a simple solution, that we get more beds which can be lowered. Is that the case? Have we got more beds on wards now to prevent people getting seriously hurt from falling out of bed during the night?
Okay, there's a few elements to that. Our beds as standard do go down to a low level, and that's across the trust, so you can take the bed down to a low level. The other type of bed is an ultra low bed, which pretty much takes it to the floor, and then in very, very extreme situations with full conversation with family and such like, you can look at going right down to the floor, but we don't use that, and that would be very, very rare that we would go right down to the floor. What we have to do as part of the assessment is, if somebody's mobile, a low bed's very, very difficult to get out of. So as part of the risk assessment, you're looking at whether that person's going to try and get out of bed, because ultimately, if you're in a very low bed, the leverage to get to a standing position is very difficult. The other thing that's part of the assessment is if somebody would be suitable for the bed rails. But again, if people are trying to get out of bed, they'll ultimately climb over the bed rails if they really want to get out of bed, and some of that's to do with cognitive impairment. So as part of the falls assessment, yes, you do have the beds that go to the different levels, but the falls assessment brings in all of those other elements to it to try and get the safest way to do it. What we do sometimes do is have to accept that we need a bed at a particular level, but depending on the patient and their condition, we can do one-to-one, or we can do cohort or whatever. And cohort means that you'll have a member of staff in that bay for people who maybe wander, who'll unexpectedly try to get out of bed. So there is a full risk assessment that's done as standard for people coming into hospital. You've also got to balance that with people's independence and rehabilitation needs and things like that. So it's really complex falls, and it's about making sure that you've got those assessments in place and that people are acting on it. But then you do get unexpected falls, of course, where people, like you say, do trip, they stumble when they're mobilising. So there is a risk assessment, but it brings in all of the different elements. But we do have the low beds, and our beds can lower down to a low level within the trust. Sorry, I think you're on mute. Sorry.
You're on mute, Councillor.
Hang on. Thank you very much again. Thanks very much for that, Joanne. Just a supplementary question, really. The acute fall 6.52 per thousand, is it not possible to break that down into people falling from beds, stroke people falling from, walking across the ward?
We would be able to get that data because there's different. When somebody falls, that goes onto the instant management system. So we do have that put down into the different scenarios of falls, and our falls team actually focus in on if there's any hot spots, so particular areas, and they'll go in and do a deep dive, it's called, to see what's happened. So certainly on the ground level within the trust and through the falls group, we can see from our instant management system the circumstances behind that fall. So yes, we've got that data as an overarching monitoring thing for purposes like quality accounts. We set ourselves against the threshold that's set nationally, and just see how we're doing against that. But the falls team are very active in looking at particular areas, particular scenarios. One of the really good things that we've done as standard for cognitive impairment, and it was one of the quality improvement pieces that they looked at last year, was the red Zimmer frame scheme, because we know people with cognitive impairment often can't see different colours. So you need a really bright primary colour for people with cognitive impairment to be able to see it. And historically, Zimmer frames were grey. And the sort of blend into the background. So we've introduced the red Zimmer scheme for that sort of thing. So there's lots of quality improvement work that goes on, and I'm just really pleased that we've got the falls team now that can focus in on things like that. In terms of the 6.52 per thousand bed days, we actually came in at threshold last year, so that is slightly higher. the thing statistically, though, if you're measuring against per 1,000 bed days, it's quite dependent on your activity within the trust. So as we know with COVID, as we in wave 1, as we stood some services down, our 1,000 bed days fluctuated as well a little bit. So our other measurement is people who have a fractured neck of femur, because that's a proxy for how many people are getting serious injury. Last year we had 22. And this year, up to September, we'd had 11 patients with a fall that resulted in fractured neck of femur, and they got a very, very in-depth review to see if there's learning, to see if we need to think about our policies and such like. Since September, we've had 2 fractured neck of femurs, so if we continue in that vein, I think we'll come in lower than we were last year, which is a positive thing, but it's just very difficult to say at this point. But it looks as if at the moment that we've had quite a significant reduction with fractured neck of femur, and we bring those all together when we get to year end to see exactly what the picture is. In terms of community bed falls, so community hospitals, because of that population, the national threshold is 8 per 1,000 bed days, and you can see from our 6-month figure that we've come under that threshold within the community hospital setting. So still lots of work to do. The next 3 years, we've actually got some medical staff who'll be joining the Falls team, and our first job is to review our risk assessment, and I think that we'll do a really deep dive into drugs next year as well, because some of the drugs can have a big effect on people's balance. So I think there'll be a couple of priorities that we'll be pulling through for the next period as we move the agenda forward with Falls. But I'm really quite proud of the work that's gone on in the first 3 years of having the strategy in place. It's moved things forward quite a bit. Okay.
Yes, thanks, Joanne. It was very informative.
Thank you.
Sorry, just to continue that, just very, very briefly. So in future reports, could we have that 6.2 broken down to falls from beds and falls from other? So at least we can keep a check as to just what is going on.
I can actually get that round and put that through before year end. So I'll ask the patient safety team to run that data, and then you can see the numbers, because it is shown in the different categories. So if that's of interest of you, I'll certainly get that sent through, no problem.
Thanks, Joanne.
Okay.
I can see another hand up, but I can't see who it is.
It's Chris McEwen.
Hi, Chris.
May I ask a question, Chair?
You certainly can, mate.
I've got some experience, but from ancient times of fall services many years ago, and there was a lot of equipment or techniques that we use, sloppy slippers, I remember. Is all of that kit still being used, or indeed has it been evolved? Yeah. And if so, are you using some of that kit on wards for those who might be at risk of falls?
Absolutely, we have the red slipper scheme, and that's it's more like a sock than a slipper, because you're right, some people come into hospital and they do have ill-fitting footwear, but we have red socks, but they have a grip on the bottom, so they've got a rubber grip. So absolutely, anti-slip socks are used as standard, as required if people don't have good fitting footwear. Yeah.
Thank you, Chair.
Thank you. Yeah. Do you want to carry on, John?
Right. The next of our priorities is the care of patients with dementia, and actually a lot of this fits into the work that we do with our falls work as well. That's not to say that people at risk of falls always have dementia, but it does often link quite closely. So the falls team work very closely with the dementia team. We do have our enhanced staff now who go into areas where people have cognitive impairment and do activities with them, which all relates to reduction in people being at risk of falls as well. So that's getting established now, and we'll have more information on how successful that's been when we get to year end. Healthcare associated infection. We've had one case of MRSA bacteremia between April and September, and we haven't had any since. If you remember last year, we had 6. Now there is a zero tolerance on MRSA, but what they do know nationally is that organisations will see MRSA. But if we go back to a few years ago where we were seeing a lot of MRSA bacteremia, the practices speak for themselves to reduce that. This patient actually had chronic leg ulcers, and the MRSA grew in that, and also where they needed intravenous devices. There was an infection in one of the skin areas where the intravenous device was. So that unfortunately got into the patient's bloodstream. And they required antibiotics to treat that. But we have had one case of MRSA bacteremia. So a big improvement on last year, but one case is one case too many, of course. Clostridium difficile. And you see at the back of the report when we get to it that there's a new way of measuring Clostridium difficile, because we actually measure hospital onset and community onset. So although it looks like the numbers are higher than you've seen them in previous years, that's because we actually pull the community onset element into there, which we didn't do in the past. It was measured separately. So our threshold is 44. We haven't had a national threshold because of COVID, but last year we had a national threshold for ourselves of 45. So we've gone below that to 44, and that's what we're trying to achieve. You'll see that we've had 27 cases reported between April and September. Some of these aren't avoidable because people do need antibiotics if they've got an infection, and we know that this is an antibiotic-associated diarrhea. But with some of them, we do have some lessons to learn, such as sample taking and choice of antibiotics. But every time we see a case of Clostridium difficile, we do a full review so that we can make sure we pull through any lessons that might be learned. I don't think that will ever have a threshold of 0, because we will continue to see Clostridium difficile within the hospital and the community setting due to the use of antibiotics. With pressure ulcers, we haven't had any hospital-acquired grade 3 or grade 4 pressure ulcers that have been avoidable during April and September, which is really good news. What we do know with COVID, though, is that we feel that it is having an impact on people's skin integrity, and that's probably to do with the fact that people are very, they've got very high temperatures, they have oxygen requirements and such like with COVID. So the tissue viability team have been very, very busy with education on the prevention of pressure ulcers, and we do have our pressure relieving equipment as standard, both in acute and community services, so that we can get the pressure relieving equipment as we need it, depending on the assessment of the patient as they come in, and then the standard things that we do in terms of nutrition and positional changes and such like to prevent pressure damage from occurrence. So that's really good news up to September, and we did see some cases last year. So as it stands now, improvement in that area, and we have got a 0 tolerance again on avoidable grade 3 and grade 4 pressure ulcers, although we do continue to see some. The next is the discharge summaries, and we aim ourselves to try and have 95% of those sent out within 24 hours of the patient discharge. At the moment, we're running at around about 90% during the period April to September. There's lots of work streams that go on to try and improve that at all times to try and get to that 95%, because we need to try and make sure that the messages flow both out of the trust and back into the trust in a timely fashion. And I'll pause there because I can see a hand up.
Hi, Joanne. It's nice to see you. You didn't retire after all.
Well, they've persuaded us to stay for a little while.
It's nice to see
for
you
obvious
anyway.
reasons.
Yeah.
So I almost retired.
Yeah. I just wondered if you thought that the new electronic patient record, which is due to be implemented in April this year, do you think that will assist discharge summaries and so forth? Because, as you know, as a committee, we've all had concerns about them.
Yeah, I mean, I think everything electronic absolutely helps, without a doubt, because the more that we can move through electronic, the more the communication moves forward. I don't know at what point we'll see the impact from electronic patient record, but in big terms, absolutely. And if we can get those data flows between primary and secondary care tied up, where everybody's working from one system and looking at one system, you know, nationally, everybody wants to see that. And I just think for the whole NHS, that'll be such a big move forward if it's very easy to access what's been going on both in primary care and secondary care, the you know, to move communication forward in that way is just fantastic. And let's you know, hope that we see the fruits of that. And there's lots of work going on around electronic patient records. So yes, anything electronic I think's positive, and we actually know that from our observations. If you remember, and I know some members came into the trust to have a look at our electronic observations, and the fact that we've got that, and it triggers to the staff if the observations go off, so that you can get that very quick review. It's just fantastic in terms of patient safety. Yeah.
Thank you, Chair. Thank you, Joanne.
Thank you. And I can see Councillor Layton, I think it is.
Thank you, Chair, and thank you, Joanne. Not wishing to delay your retirement much longer, but I was just wondering, you mentioned, it probably picks up on Wendy's point about the electronic sort of recording. You mentioned earlier about the impact that you've already started noticing that COVID is having on you know, people's skin integrity, and the fact that it's adding extra sort of problems. Do you have a facility to monitor and sort of actually make a record of you know, additional sort of you know, add-on sort of problems that COVID's having? And do you anticipate in your moving on that you'll need to actually put a category in here that will have, you know, sort of, you know, COVID-related sort of issues that you're going to have to monitor moving forward? Thanks.
Okay. In terms of COVID, it's a really interesting and very key question, actually, because that's what we're all dealing with at the moment, both in and outside of hospitals, and on personal levels as well. And we haven't been given categories as such to look at as yet, because I think everybody's dealing with the pandemic at the moment. In terms of pressure damage, we always monitor that really closely if there's any pressure as standard. So regardless of COVID, because anybody who's sick, there's an effect on skin integrity. So it's right up there in the importance category. So all of our patients are assessed for pressure damage. They're assessed for what needs to be done and what equipment they might need to prevent pressure damage. And if there's a risk of pressure damage, we do something called a Waterloo score, which is really easy for our staff to use, and it scores up all of people's comorbidities and their condition and what they're presenting with, and that doesn't change with COVID. That happens as standard. and it shows a risk of somebody developing pressure damage, and then the care plans build around that. So I think what we're seeing with very sick people coming in is that there's a higher risk for skin integrity, but I don't think that's particularly related to COVID. I think that's with anybody sick. It's just that we've had a more concentrated admission period of people who were sick with COVID, because by the nature of COVID, you're admitted to hospital if you're sick, and a huge amount of people manage to stay home with it. So I think going forward in terms of COVID, once we come out of these waves and we get the vaccination programs moving, I've got no doubt that there'll be a monitoring tool that's given to us nationally, and we'll absolutely build it into the quality accounts. And also, even if that's not there, it would be remiss of us not to do something into the quality accounts about COVID and effects it might have had, but I don't know that it'll be specific down to things like pressure damage, because that comes in the bigger picture. Does that answer what you?
Yes, thank you very much. No, that's
thank
really
you.
helpful. Thank you.
So patient safety incidents, we've had a 3% increase in incidents reported, and you know that this is quite dated information, so that's the period October 19 to March 20. It's very live that we report the incidents within the hospitals. We do have live data, but when it comes back to us nationally, that's when we get the statistics around it. So we have had a 3% increase. Diversely, that's very, very positive. We absolutely encourage our staff to report incidents, because that gives us a picture of what we want to dig into, what we want to look at, and where we want to focus our attentions. And we did have the big near miss campaign last year, where we wanted people to report incidents that hadn't actually happened, but where somebody thought that would have happened if I hadn't recognised it. And we actually had a 30% increase in near miss incidents. So that's been a very successful campaign. So I'm pleased to see that incident reporting's gone up, and I hope to see it go up and continue to rise, because that's how we get our focus of our work. Management of patients with sepsis, the regional screening tool's actually embedded now, and it's integrated into all of our electronic systems. So that means that whenever you do a set of observations on a patient, if they have an early warning score of 5 or above, it'll ask the question, does your patient have sepsis? Now, you can often get an early warning score of 5 or above for other things. If somebody came in, for example, with a heart attack, no doubt initially their early warning score would be 5 or above, but it asks the question of the staff, so that every time that happens, you're considering, does your patient have sepsis? It might be for something unrelated, but it's that constant reminder to think about sepsis whenever that early warning score triggers, and that's now embedded. So that's really, really good news. Nutrition and hydration, we've got the quality metrics, and they are monitored, and there's monitoring tools at ward level to allow audit to happen. And we're very proud to say, with our end of life and palliative care, that we actually got outstanding from our recent CQC inspection. So that's just huge for us, and something to be very proud of. If we're getting that right, it's very important. And as you know, we do have the acute intervention team, so they review patients 24 hours a day if their condition's deteriorating. Now, that's not just for people who need resuscitation or need intervention to improve their condition. It also triggers for people who are reaching the end of their life, to make sure that the care is appropriate and that they've had the appropriate reviews. And the acute intervention team have a line straight to our consultants, palliative care consultants, as required. for patients nearing the end of their life. So really, really good work there. The next couple, so our responsiveness to patients' personal needs, which is the National Patient Survey, and then the staff survey, they're both annually reported. They're annual reports, so they'll come through in the next couple of months, and we'll be able to see where we're at with those. And I can say Councillor Tostovan.
Yeah, Councillor.
Yes, thank you, Chair. I was just going to say that I think in the last report, if my memory serves me correctly, those figures weren't particularly encouraging in terms of the percentage of staff who would recommend the trust to family and friends. So it would have been interesting to see some more data. But what you're saying is it only appears annually. Is that what you're saying?
It
so
is.
Right. OK. So we'll look out for that next time coming through. Then
it's a staff survey actually. So it comes out once a year. Now, I'm just referring back to our last report. So in 2018, we were at 58%, and in 2019, 61.3%, but the national average was around 70%. So there was improvement, but we hadn't got to where we wanted to be. The other two staff survey questions that are pulled through the quality accounts, so that's the harassment and bullying and equal opportunities, they actually came in, they were both improved, and equal opportunities actually was better than the national average. So but you're right, the recommendation we were lower on.
Yes, I remember that one. So we'll look out for that next time around. Thank you very much.
Absolutely. And that report's usually embargoed for a little while. It's one that we often don't manage to get into the draft quality accounts, but they were talking about lifting the getting it out earlier, because nationally people have said it's quite difficult in terms of quality accounts, that you're not getting that result until it's almost ready to publish. So I know nationally they were looking at that and seeing if we can get that through earlier. So hopefully we will.
Okay, thank you.
The next is the mortality indicators, and as you know, we do have now our mortality reduction committee, and we are adhering to the learning from deaths policy that came out a couple of years ago, and we do mortality reviews to see if there's learning. And what we do is we link that very closely to patient safety, so that while we're doing the mortality reviews, we're also checking whether there's been any incidents related to the patient as well. You can see from one of our mortality indicators, we were absolutely as expected, and then on the other one we slightly higher than expected. So we have done a review of the one that looks higher. Depth of coding. Now, depth of coding looks at what did the patient come in with, and also what were the comorbidities, and also is somebody palliative. And it has an effect on our mortality indicator. So if we don't capture everybody's comorbidities and just code people for what they've come into hospital with. So to give an example, if somebody came in with a heart condition, but actually on the background to that they had liver disease, kidney disease, and lots of different diseases, that would change their comorbidity, and it would change their likelihood of dying. So depth of coding is really, really important in terms of mortality monitoring. It doesn't mean that we say this is the reason for things being higher, but it aims us into what do we need to review, what do we need to look at. So we do know that we need to do some work on depth of coding, and we've got a working group actually doing that. The other indicator that came out higher for us was acute kidney injury, and we've now got acute kidney injury nurses in post. So that's for early recognition of acute kidney injury, so that actions can be taken to improve that and get the relevant teams in to look at that. And I can see a hand up.
Yeah, it's Councillor Donahue. Just to go back to friends and family, are people actually completing these?
Yes,
Yeah.
we do. Yes, I haven't got the latest results, but what I can do is refer to last year. But yeah, that campaign's still ongoing. It was
good.
stood down during COVID nationally. So there was a period this year, which is why I don't have results, but it's certainly getting relaunched, and there is an expectation for trusts to continue with them. So we don't have data for the first part of the year because nationally it's stopped, but it's getting relaunched. Absolutely. Yeah.
Excellent. No, it's nice to know. Thank you.
Okay. Right. Thank you. Reduction in 28-day readmission to hospital. If you remember, we always had an indicator of 7% for that, but that was because there was no national indicator for it. And over time, and what we agreed for this year was that we would aim for 11%, because we know that around 12% of our patients, a little bit more, 12 point something percent, are being readmitted to hospital, but that can be for lots of different reasons. So the ambition was too big. So you'll remember last year we presented to you that we wanted to change our ambition with that to 11%, so that we are still pushing ourselves for review and looking at reasons for it, but we don't think we'll ever get to 7%. So that work continues. In terms of the emergency department indicators, I've put a little bit more detail at the back of the report, so I'll come back to that. But Councillor Heslop?
Yes, thank you. I was just wondering about the readmission rates. Has that been, are you able to break that down into sectors for which is the most prevalent and least prevalent? And I'm thinking of respiratory, GI, mental health related issues such as self-harm. Is this readmission rates, are they able to be broken down? Thank you.
I don't know the answer to that, Councillor Heslop, but I'll certainly ask the question. I know that it's been audited in the past. I think that the difficulty with readmission is if you just look at readmission, you can probably get the figures, but it's what sits behind that. So was it for the same reason? Was it for something totally unrelated? And that takes a lot of work to audit that. So I don't actually know the answer to your question. I'm going to just ask Gillian if she does, and otherwise I'll take that away and I'll find out what we do have, and then I can share it.
Thanks very much, Joanne.
I don't know any more than you, Joanne, other than, like you say, having to investigate each patient's individual notes to understand the cause of the readmission, which would be a huge piece of work, but we can certainly look at it and take it back for discussion.
Okay.
Yeah, I mean, I just remember sort of around about 7 years ago, a massive audit being undertaken about readmission, diabetes, it was under Dulcie Wells, etc. Diabetes, COPD, and sort of self-harm related issues seemed to be the big three from my memory at the time. So I was just wondering.
Yeah.
But thanks anyhow.
No, I'll take that away and I'll get you an answer on that. So I'm going to come back to the emergency department indicators. Patient reported outcome measures, and this is where if somebody needs a hip replacement or a knee replacement, it's also varicose veins, and hernia. First thing to say is varicose veins and hernia, they've removed from that national reporting, but the knee and hip replacement, and it's a questionnaire basically where people are asked what's the health like before they have the operation, and how do they feel the health gain is following the operation. this is very, very, very dated information by the time we get it. So even when I get it into the quality accounts, we don't have that information for the latest period. But even when I get it into the quality accounts, it's always a year. It's from the previous year, but we haven't got the report out on that, but we will include it. In terms of maternity standards, as you know, what we pull into quality accounts is 12-week booking, breastfeeding, and reduction in smoking at delivery. And you can see for the 6-month period that we've reached our aims for that. I think, and if I'm still here, maybe not, but I think we probably want to pull in more for next year, because you'll have all heard about the Ockenden report, and that was where they looked at maternity mortality in an organisation, and there's a big learning exercise come out from that organisation in the last few weeks, and everywhere's been asked to monitor themselves against the Ockenden report to make sure that we're in place with all of our maternity standards. And I think just to keep in mind for when we're looking at next year's, I think we should build in our standards against the Ockenden report into the quality accounts for next year, so that we're really keeping that live and we're continuing to monitor it through. So it's all a moving thing with maternity standards, but I think that'll be a very good indicator of how we're performing in terms of maternity care. So we'll look to pull that through for next year. Paediatric care, as you know, we do have the paediatric unit adjacent to the emergency department. We did have to use that during wave 1 of COVID, but that space, but that's back in place now. And the paediatric pathways continue, so that we make sure that paediatrics, that the teams immediately come to the emergency department if the children come through that stream. And then excellence reporting, we've got in there because from your feedback, you wanted me to make sure that we always say the good things as well. So we chose excellence reporting, and that actually comes through the incident monitoring system. And it talks about where staff have gone the extra mile and where they've done really, really good things. And the staff get an award every time that there's an excellence report put in about them. And we do pull reports quarterly for the care groups to just celebrate the good things that our staff are doing, which is lots, as you can imagine. So we'll pull that through. We'll pull more detail through the report. Excuse me. So finally, in this final section, I need to report one never event between April and September. And this was a patient who was having eye surgery, and they put the wrong strength lens into the eye. The first lens was damaged, and then when they'd inadvertently put the wrong strength lens into this patient's eye. The patient themselves is absolutely fine, and they'll be reviewed to see if they need to change the strength of that lens, or whether the patient will manage with the strength that's in there. So we're busy doing the review about that to see the circumstances around it, but it's certainly a human error that the wrong strength lens was chosen and inserted into the eye. So lots of work unpicking that to see what's happened there. Clostridium difficile objectives, I've just got that in there so that you can see how we measure Clostridium difficile as opposed to not last year, because it had come in last year, but from years before that, and that's where the change in the numbers have come from. And then finally, in the appendix, I've dropped in just the emergency department activity, and I know the last time I spoke to you, you asked me to pull that through. The full detail of this does go into the quality accounts anyway, but the first table actually summarises the performance over the period March to the end of December 2020. Both emergency departments have operated with separate COVID and non-COVID streams, and supported by staff deployed by other services. Our performance exhibits a similar trend to the non-elective, so the emergency admissions and length of stay, and it just shows that it's all interlinked actually. We can see that there was a sharp reduction as COVID wave 1 became embedded from March onwards, and then as wave 1 began to recede between May and June, all of the graphs showed a similar growth trend until we hit wave 2, which was round about September. And during the COVID period, Darlington did achieve that 4-hour wait standard every month between May and June, and Durham didn't get that 4-hour standard of 95%, but they did get a 94% between April and July. But as our emergency attendance activity has increased, we've felt the impact, which I think everybody has, and I think we're all well sighted on the difficulties that the NHS is facing. What I would say is our staff have moved from back of house services back to the front line to support. It's very, very busy, as I'm sure you can imagine. Everywhere it's exceptionally busy, but they're coping really, really well, our staff, and we've pulled, like I said, back of house staff, and we've had really good support from people coming out of retirement and such, like me included. But but what else would we do actually? And it's although it's very, very busy, you do feel quite proud to be trying to help with the agenda that we're facing. And that's it. I shall stop there.
Thank you, Joanne, as well. Very informative. Thank you. Any questions from anybody? Oh, Councillor Layton.
Thank you, Chair. I don't know whether it's something, Joanne, that you can actually quantify, but is there a possibility that some of the numbers, when you've got the 4-hour waiting, that a lot of people have been discouraged who previously would have turned up at A&E, sort of for the slightest thing? And I know from experience and from anecdotal sort of comments from friends and colleagues, just how tiny some of these sort of incidents are. They'll come in with shaving cuts and things. So do you think there has been a sort of discouraging of people going in? So it sort of, that possibly does bring the, waiting times down a bit. I know you can't quantify that very easily. I just wondered what your opinion on that was. And I just wanted to say just a massive thank you, for the report, but also for staying with us and helping us through it, and to all the staff that had to come out of retirement or come from back rooms to frontline. It's been very much appreciated. Thank you very much.
I wouldn't do any different. I think after 30 odd years in the NHS, I would never have been able to settle if I wasn't part of it. So it's not a hassle to me at all. I was pleased to do it and do my bit. Gillian, I don't know if you want to start with the question about the activity through the emergency departments.
I think, like you say, it's difficult to quantify, but what we did see in general terms was some reduction in people coming into the emergency departments at the height of wave 1. But actually that started to pick up again around September and went back up to really what we would expect to be seeing through the departments. And actually we've just started some campaign materials over the last few weeks because we are starting to see those inappropriate turn-ups again. So a lot of our colleagues within the department have been helping us with some social media messages around don't come unless it's actually life-threatening or really, really serious, which is what they're there to treat. So I think there probably was a slight reduction over the summer months. I mean, it's always less than anyway, but more than we would have expected usually. But we've seen that grow again. So we are managing that as well as COVID at the moment.
Excellent.
Thank you very much.
Councillor Heslop.
Yeah, thank you. And just to reiterate what Councillor Layton said about thanking your organisation. Regarding the staff, basically what I'd like to ask is have you got any figures on vacancy rates? And the other thing is, over this time, you know, that we're of COVID, etc., about has there been an increase in staff sickness? And my final bit is there no staff shortages or increased sickness, etc.? And you can see where I'm going. Thank you.
Shall I answer, Joanne? Yeah. I don't have the actual figures in terms of the rates with me at the moment, but we can look to share some of that. I think what I would just say on it is it's something that we monitor daily through a Gold Command meeting as an organisation. Obviously, we do see the impact of COVID on staffing levels, so obviously we've had to manage that in terms of an additional pressure than usual vacancies. We have a brilliant HR team that are managing all that for us, so it's never really been something that's caused us unnecessary consequences, so we've been managing it very well through our usual processes. I think the most important point that you raised there was around the health and well-being of the workforce and what we've done to support them during this. And actually we've done an awful lot of work around that, not just frontline, but those support staff as well that have either had to change role, are doing a slightly different role, or just still doing their usual role, but obviously facing not just the pressures at work, but also not underestimating the personal impact of this as well. So everything that they're dealing with at home, family, lockdown restrictions and all of that. So we established quite early on in the pandemic a health and wellbeing hub, which is a resource that all of our staff can access within the organisation, and we have on there a range of materials, information, advice, and also links into national resources. And we've done a lot of work around promoting that and ensuring that staff are linked into that, and doing regular briefings with them as well to encourage the use of that. And really, we've done a lot of communications internally around supporting each other and the kindness agenda, stability, and a lot of that. So health and wellbeing of the workforce has been one of our main priorities during this.
Okay, thank you very much, and that's really good to know. And as I say, on my behalf, thank you to the organisation for all you do.
Thank you.
Councillor McEwen.
Yeah, I'd echo the thanks. It's as in my kind of language, it's been a tough gig, and it continues to be a tough gig. Just some observations. There was a report today about I think it was ITU staff survey. 50% of turned to sort of alcohol or had suicidal thoughts. I think it was Health Service Journal. So clearly there's an issue, and it's reassuring to hear that you as an organisation recognise that issue and you're taking steps to support staff and mitigate that. Just another comment on the A&E and an increase in I'm going to call them inappropriate attendances. Just don't forget that, you know, the council has the ability to push out messaging on social media. I know Councillor Nicholson's on the call, he pushes out messages, and so I think it's got to be a community effort and not just yourselves trying to get that messaging out. And we as ward councillors and community leaders have various communication mechanisms. So my advice to you, which is something I always say, is use the assets within your community, and we as councillors can quite often support and reinforce that messaging.
Thank you, that's very much appreciated. The more people we can reach, as you say, and the more people that share those messages, the more impact we will have.
Any more questions? Well, on that note, then I'd like to thank Joanne and Gillian for popping along.
Thank you.
Thank you, everybody.
Thank you.
Thank you. Bye-bye.
Thank you very much.
Thank
Bye-bye.
you.
Thank you very much.
Bye.
Bye.
Thank you.
Anna, can you get me that number, please?
Yeah, so just bear with me.
If you can.